So we're just going to go through the AUA guidelines for BPH and just kind of give you the historical context for why each guideline is there. Admittedly, there's, as we talked about yesterday, there's hundreds of procedures now we can do for BPH. And so we're not going to, the goal here is really to just give you some context for the AUA and why they think about different procedures in different ways. So it's not going to be an exhaustive discussion by any means, but hopefully just give you a flavor for the options that the AUA guidelines are based on. So by way of disclosures, these are the procedures that I personally perform. I do not perform HOLIP. I do not perform aquablation, although we are trying to acquire that at our hospital. I do not perform the iTind. So again, we'll do a quick, we'll review the AUA guidelines. We'll look at some of the data behind those guidelines. And then at the end, I'll give you just my personal algorithm for how I think about treatment options based on the patient presentation. And the take-home point is, this is not meant to be prescriptive. There's usually more than one right answer. So on the spectrum of therapy, we hinted at this yesterday, but this list gets longer and longer each time I give this talk. But over on the left, we have some of the less invasive options: Optilume, Urolift, or Zoom, iTind. I would argue maybe Optilume and iTind would be even further to the left because they are fairly even more minimally invasive. PAE is probably on there, and then as you progress, you get the more surgical interventions: the TURP, the TUIP, the laser therapies, and ultimately a simple prostatectomy. And so on the spectrum, we go from ease of use, minimal morbidity,